All right, so today we're going to be talking about the pelvic floor and the specific pelvic floor dysfunction of urinary incontinence. So we'll talk about the initial treatment of the different types of urinary incontinence, and then we'll talk about the first line treatments, and if those are not adequate in controlling your symptoms, we'll talk about what else is available for you. All right, so this is an illustration of the female pelvic floor. So the pelvic floor includes the muscles, which if you can see my pointer here, it looks kind of like a sling here. So it has that sling-like appearance. And the pelvic floor also includes the organs, which include the bladder, the uterus, the vagina, and the rectum. So the bladder, vagina, and rectum penetrate those muscles of the pelvic floor, and everything is held together by ligaments and connective tissues. There are several disorders of the pelvic floor. So this can include pelvic organ prolapse. That's when one or more of the pelvic organs slip down from their normal position and actually bulge into the vagina. Dysfunction of the pelvic floor muscles, which can lead to problems with intercourse or pelvic pain and other issues like urinary or fecal incontinence. So today we're going to focus on urinary incontinence. So what is urinary incontinence? Urinary incontinence is any involuntary leakage of urine. 75% of older women will have some sort of form of urinary incontinence. There are several different types of incontinence, but we're only going to focus on the two most common types today. So first is stress incontinence. So this is loss of urine with any physical activity or movement. So most commonly coughing, laughing, sneezing. Often I hear from women that they can't run anymore or they can't jump on a trampoline with their kids because they'll leak with every bounce. So about 1 in 3 women over the age of 45 have stress incontinence. The second type we're going to talk about today is urinary or urgency urinary incontinence. So this is the gotta go type. So this is the sudden urge to go to the bathroom that's so severe that you may leak on your way to the bathroom or leak as you're pulling down your clothes to go to the bathroom. You may have also heard the term overactive bladder. So this is just another term for frequent urges to go to urinate. So even when it's inappropriate, like when your bladder's not even full or you just went to the bathroom. This urge can over time lead to urge incontinence. So there are often triggers with this type of incontinence. So you may not have the urge to go to the bathroom, and now all of a sudden upon hearing running water, seeing that public bathroom, or putting your keys in the front door, you all of a sudden develop the urge to go to the bathroom. About 15% of women of all ages have this type of urinary incontinence. So you can actually have a combination of both the types, so stress and urge incontinence, and this is called mixed incontinence. Each type is actually treated very differently, so it's really important to understand what type of leakage you have, and what your goals are. All right, and I'm going to turn this over to Sarah Suarez, and she will talk about the the evaluation.
So when you come in for a visit to talk about incontinence, we'll review your medical history and any medications that you're taking to see what might be affecting your incontinence, what might affect the success of your treatment, and what may increase your risk with certain treatments. We'll be focusing on the symptoms that are of most concern for you, but we're also going to be investigating if you have other pelvic health conditions that might be affecting things in your lifestyle as well. You can expect to have a physical exam. You're likely going to be undressed from the waist down. We're going to be looking for other pelvic floor conditions like prolapse that Dr. Grakowski mentioned earlier. We'll assess your tissue health and also your muscle strength. We might get a urinalysis to look for a bladder infection, and we'll complete a bladder scan to help us determine if you're emptying your bladder all the way. At the end of your visit, we'll again focus on the symptoms that are most problematic for you. We'll review anything we found during the exam, what contributing factors you might have, and what your diagnoses are. We'll talk about all the treatment options specific to you and what's involved in those options and what risks there may be. But ultimately, we want you to choose the right treatment for you and your lifestyle. That's all I got for that one. Next slide, Allison. sorry, for urge incontinence, there's actually quite a few things that you can do before you even come in. Changing what you eat and drink can make a big difference. There's a number of bladder irritants that can make you go often, go now, or leak with that. When I discuss this with patients, I talk about the big six. The big six are the ones that I've noticed make the most difference. They include any type of caffeine like coffee, tea, or soda, any type of carbonated beverage like beer, soda, mineral water, any type of citrus like lemon, lime, kiwi, pineapple, grapefruit, even citric acid, which is found in a lot of bottled beverages for a preservative. And lastly, tobacco, alcohol, and artificial sweeteners. There's a lot more things on the list. And if you do a web search for dietary bladder irritants, you're likely to find a complete list, or you can go to the Mayo Clinic patient education website and they have a list there. I do want to say that cutting back on these things can make a difference, but eliminating them completely is the best thing that works. I always tell patients that it's really good if you can at least figure out what things might contribute to why you're having some incontinence. For example, you might decide that coffee, if that causes you problems specifically, might be a special treat rather than an everyday thing. And then on those special days where you decide to have coffee, you might just be a little bit more prepared for your urgency or your leaking. Or there are some people too who come in and they say, nope, not giving up my coffee. I'd rather put up with the leaking of urine. I also often talk to people about how much they're drinking. You want to make sure you're drinking enough because concentrated urine can also be a bladder irritant. The way I typically gauge this is your urine should be a nice pale yellow color. If it's clear, you're drinking too much, and if it's dark, you're not drinking enough. If one of your problems is having a significant urge before you get to the bathroom, one of the things you can try to do is schedule your bathroom breaks so that you get there before the urge. Your body can then get used to going to the bathroom without that urge, and then you can gradually start to increase the amount of time between bathroom breaks. Another really useful thing is pelvic floor physical therapy. I often see quite a bit of success with this. I think patients really learn lifelong skills to get longer term results this way. About 40% of women coming in don't actually use the right muscles when they do Kegel exercises. So part of physical therapy is coaching and teaching you to identify the right muscles to use. But the physical therapist will also assess the entire pelvis, taking into account other issues like back pain and alignment issues. They may teach you other techniques to help suppress urge. And the physical therapist will also reinforce a lot of the dietary changes and bathroom habits that I mentioned earlier. Treating other contributing medical conditions also makes a difference. Prolapse and constipation are probably two of the biggest ones. But sleep apnea, diabetes, smoking or other tobacco use, limited mobility, dementia, and vaginal atrophy are others. Another option that you can consider is medication. Medications often sound appealing for people because it's just taking a pill. The options that I talked about earlier, however, can sometimes be considered an inconvenience or are time consuming. And while medications can be convenient, many have side effects that can be limiting. In my experience, patients will often choose not to start or they'll discontinue medications because of those side effects or because of cost of the medications. But what's really great about all of the options that I just talked about are that you can choose to start with one option or you can combine them and see, you can try to get the best possible outcome. But if these things aren't working for you or if they're just not enough, Dr. Grakowski is going to talk about other things that you can consider for treatment. Unmute, Allison.
Yes, thank you. So other options that we have when the initial treatments aren't effective enough or fail for you, one can be Botox. So this is actually injected into some of the muscles of the bladder. This actually paralyzes them and it allows you to hold more urine in your bladder, and it can decrease those urge symptoms as well. This procedure is not permanent and will need to be completed about 1 to 2 times a year. The rates of symptom relief are about the same as with a medication, so pretty good, and about 27% report complete resolution of their urgency symptoms. There can be complications with this procedure though, so you can have a difficulty emptying your bladder because of the paralyzed muscles, and it can increase your risk of urinary tract infections. This procedure can be done in the clinic or in the operating room. Other options would be nerve stimulation. So nerve stimulation helps control the nerves and is thought to change the messaging to the bladder. So there are two types of nerve stimulation that can be done. First is the tibial nerve. So this is a nerve that runs near the ankle. The tibial nerve does connect up to the sacral nerve, and the sacral nerve is what controls bladder function. So this procedure is similar to acupuncture, where a needle is placed near that nerve at close to the level of the ankle, and small electrical pulses are sent to the nerve. This is done in office. Each session is about 30 minutes, and you usually do it once a week for 12 weeks. The next step is sacral nerve stimulation. So this is when a device is surgically, or an electrode is surgically implanted near the spine. So this is a two-part process shown here in the pictures. So the first part, the lead is placed and the battery is external or outside the body. For a couple of weeks, a diary is kept, and if there is significant improvement of your urinary urgency and incontinence symptoms, the patient will continue on to the second step. In the second step, a battery is surgically then implanted into the buttocks area, and you can see up here how where the battery is implanted. In one study, 62% reported an improvement of their urinary urge incontinence with this device. Now, this device is considered kind of last line, so when all other options fail, this would be an option for you.
So stress incontinence is that leaking with coughing, laughing, sneezing. Some treatment or lifestyle modifications for stress incontinence are similar to that of urge incontinence. Making sure you're drinking an appropriate amount of fluids, making sure you're taking the time you need to empty your bladder. And then sometimes we recommend double voiding. Double voiding is when you stand up after you go to the bathroom, maybe shake around a little bit, sit down and try again. Another thing that's similar is physical therapy. They might do a few things differently in physical therapy for stress incontinence, but they're going to teach you techniques and ways to use the muscles that can help prevent your symptoms. But like Dr. Gurkowski said earlier, stress incontinence is different than urge incontinence, and so it requires different treatment options. Similarly, medical conditions are different as well that might affect that stress urinary incontinence. Chronic cough, asthma, COPD, chronic constipation, being overweight or obese, atrophy, and limited mobility. Another option for treatment is in the picture on the right there. That's called a pessary, and that's a device that goes inside the vagina. And its job is to hold things up and in place if there's prolapse present. And then that knob that you see pushes the tube that carries urine to the outside, and the pressure from that helps to keep your urine in when you're coughing, laughing, and sneezing, but it's not enough to keep you from going to the bathroom when you need to. When you use a pessary, you're not supposed to be able to feel it at all. Its job is to help with any sensation of pressure and bulging, and to keep the urine in when you want it in. And the nice thing about using a pessary is it's a non-surgical way to see if your symptoms get better or improve. And if the pessary doesn't work, you can always move on to another treatment option. I often use pessaries if someone doesn't want to have surgery, if they can't have surgery, or if you're not done having babies. Surgery is not always a good idea, so a pessary is a good option.
All right. So when initial treatment fails, what are some of the next steps we can do? So stress incontinence is usually related to weak support around the urethra. So everything that we have surgical or procedure-wise relates to building up some of that support. So urethral bulking agents are when a substance is injected around the urethra to provide more support. So this usually wears off after several months, so repeat injections are usually required. A mid-urethral sling is a medical grade permanent mesh that is placed under the urethra to provide support. So small incision is made in the vagina and the mesh is pulled through either the back of the pubic bone, as can be seen here, or through the groin with a needle. So greater than 90% of patients are happy with their results after placement of this mesh sling. It is considered a low risk procedure, but some of the complications may include bleeding, difficulty in emptying your bladder after surgery, which may require going home with a temporary catheter, and the mesh being exposed in the vagina. Another option is a bladder neck suspension. So this is done within the abdomen, and it's not as common as it used to be, and that really has to do with the success of the minimally invasive mid-urethral sling. So the sling is minimally invasive. It's a very simple procedure to do. So this suspension is done less and less. So this can be done when you don't have access to the vagina. If there's another surgery being completed at the same time, so it can be done concurrently, or if there's a reason that you can't have mesh in your body. So in summary, the chances of urinary leakage increases with age. So we want to focus on decreasing symptoms through lifestyle changes. And if those are not enough, we do want to explore all those other treatment options that are available to you. All right, and this time we'll proceed with any questions.
Yeah, well, thank you very much, Dr. Krakowski and Sarah. As indicated, we're going to turn over to questions and answers at this time. We do have a number of questions that have been submitted ahead of time, and thank our guests for proceeding and doing that before the program began. So with that, I'm going to direct these questions to both of you, and feel free to whoever feels most comfortable answering it. So maybe I'll just direct this answer and right to Sarah. Sarah, you talked about medications. Are there side effects or things I should know about these medications? Or are they pretty benign?
Yeah, so medications for overactive bladder or urinary incontinence, there's two different types, and one of them is much more common because they've been around a lot longer, and they've just been around a lot longer, and they're better covered by insurance, quite honestly. Those medications all have very similar side effects. Things like dry mouth, dry eyes, constipation are very common. Other serious side effects like cognitive decline have been noticed as well. And so I don't always want to use these in anyone who's been having issues with their memory already. The other type of medication is a little bit newer, but it's still been around for about more than 10 years, quite honestly. And that medication can increase your blood pressure slightly. It can cause a runny nose. And in rare circumstances, it can increase your heart rate.
Thank you, Sarah. I'll remind guests once again, the Q&A at the bottom of your screen there can be used to submit those questions. So feel free to do that. So I recently had surgery for a prolapsed uterus and bladder. Prior to this, I had no incontinence issues. Can you explain to me why this may be occurring now?
I can take that one.
Sure.
So what can happen is when you get your prolapse fix, so whether it's removing the uterus and pushing the bladder back up into its position, or taking the top of the vagina and anchoring it up so it's all kind of in its anatomically normal position, this can actually cause somebody who didn't have stress incontinence before to now have leakage because you're changing the anatomy. Sometimes we'll see women who had stress incontinence for many years, they develop prolapse and it actually goes away because with that prolapse, it's kinking off the urethra. So it's preventing the leakage when you cough, laugh, sneeze. So it is something that we'll often discuss with patients if we're proceeding with prolapse surgery, because there is a chance that you may develop incontinence after this surgery. So about 40% of women will develop incontinence after the surgery, so that some women may opt to have a sling placed at the same time as their hysterectomy and repairing that bladder.
All right, thank you very much. I'm a young woman. I just had my first child. I know my mom suffers from urinary incontinence. Is there anything I can do to prevent myself from facing this in the future?
Sure, I'll take that one. Or Allison, do you want to answer it? Go ahead.
I think we kind of both can. So I'll start, and if you want to fill in anything, Sarah. So there are some things that you can do to help prevent incontinence. And one is, maintaining a healthy lifestyle and a normal weight. We know women who are overweight, that does put additional pressure in the abdomen, which over time can increase that risk. Just simply the act of carrying a baby does increase your risk of incontinence. And that's, if you want to have children, there's not much you can do about that, as well as having a vaginal delivery. But what you can do is after you have babies is work to strengthen those muscles back up. And we often do that with pelvic floor physical therapy. Also, not smoking. Smoking does decrease the quality of the tissue. So again, that has to do with some healthy lifestyle changes, as well as limiting things like constipation. So anything that really causes excessive straining. So years and years of constipation where you're always straining can contribute, as well as maybe some extreme things like powerlifting. We know women who lift very, very heavy weights for long periods of time are at increased risk.
Sarah, do you have anything else?
No, Allison or Dr. Gurkowski covered it pretty well.
All right, well, thank you. We touched upon weight, but that seems to be a common question. So again, keeping the weight off is a good idea, the best we can. We know with oftentimes during maternity times, we do gain weight. Obviously, taking the weight off is highly recommended the best we can, correct?
Yes, that would be true. I will say that I've seen patients who have been able to lose some weight. Their stress urinary incontinence, especially symptoms, can get better.
Yeah, thank you. Can you tell me a little bit more, Sarah, about physical therapy and how that works?
Sure. So our physical therapists are great here. We have people who are especially trained in pelvic floor physical therapy. I know a lot of patients are concerned because they feel like they're going to go to PT and they're going to be out in the middle of the PT gym with everybody around them. For pelvic floor physical therapy, you're in a private treatment room and you're one-on-one with the physical therapists. They do need to do an exam. They do need to do a physical exam. But they're basically going to be teaching and coaching you to use your muscles. They may use something called biofeedback, which is where they may put some stickers on the muscles on the outside, which is attached to a computer. And in the computer, they might have on the screen a picture of a flower. And with the flower, when it's opened up, you can see that your muscles are relaxed. And when the flower closes, your muscles are squeezing. And so that way you get some kind of feedback to know that you're using the right muscle group. They can do a lot of other things too for things like pelvic pain or pain with intercourse. Sometimes they do use a device that helps to stimulate the muscles to get them to work again. So there's a variety of different techniques that they use to help.
Thanks, Sarah. So it sounds like you're describing what I have read about or others have read about is Kegel exercises. Do they really work? Should I do them?
Yeah, Kegel exercises are a wonderful thing. I know I have a lot of people who come in and they say, I've tried Kegel exercises, they don't work. And oftentimes when that happens, when I'm doing an exam and we're trying to get those muscles working, people will use their butt muscles or their tummy muscles or a lot of the other muscles that are around there, but not the actual pelvic floor. And that's why sometimes people think Kegel exercises don't work, but they can be really helpful. And really, I just can't say enough how I see long-term results and lifelong skills learned from PT and doing physical therapy and Kegel exercises.
All right, so you're an advocate.
I am definitely an advocate of physical therapy.
All right, thank you. Is it possible for my incontinence to come and go?
It is possible for it to come and go. So there can be triggers out there like food where you don't even notice the association. So you can have urge in issues and incontinence, and then it goes away for a period of time because you're not having some of those same exposures. And as we discussed before with stress incontinence, changing of the anatomy over time can actually make some symptoms better. So it is something that can happen. It can be associated with medications as well. So that is something to just be aware of.
Okay, thank you. My only symptom is feeling like I have to pee all the time, even though I just went to the bathroom. I've had nothing to drink all day long. Is this truly urinary incontinence, or what would it be?
So without urinary leakage, it's not incontinence, but it does sound like overactive bladder. When you have that urge to go all the time, even though you don't have a full bladder.
Thank you. I have a tendency to get urinary tract infections and have incontinence. Are they related?
So urinary tract infections can cause leakage of urine, and so that's oftentimes why we'll check for an infection. Otherwise, oftentimes bladder infections can be related to prolapse, which is something we talked a little bit about earlier. So we always want to make sure that there are no infections going on.
Thank you. I'm going through the list of questions as we speak here. Let's see here. Dr. Grakowski, you talked about mesh. Is that safe to put in my body?
So this is a big question that I get a lot when we start talking about mesh. And I have some women who immediately, when you mention mesh, they're like, nope, I've seen the TV, I've seen it on the news, I've seen some of those commercials, and they're very apprehensive. So I do want to clarify that the mesh used in this procedure is not the same procedure that you may have seen on the news or TV in the last several years. So at one point, they were using large sheets of mesh to hold up either the bladder, uterus, or rectum within the vagina. And these products, there was some significant complications with those, and they are no longer on the market. So with the mid-urethral sling, this is something that's been around for quite a long time. It is FDA approved, and it's considered totally safe for the treatment of stress urinary incontinence.
All right, well, thank you. We're quickly coming to the end of the questions here that we have submitted. So if you do have further questions, please feel free to submit them via the Q&A below. I'm experiencing worsening incontinence. I used to just have it when I'd come home and could not make it to the car, to the bathroom quick enough, but now it's far too often. Can you kind of go through again what's happening here or what I should be thinking about?
It sounds like overactive bladder, urge urinary incontinence type symptoms, and kind of going through, the steps that we talked about, considering any dietary things that influence you. I will say that, for instance, like coffee stays in your system for more than 24 hours. So even if you drink it in the morning, it can affect you all day long, including at night. So another common complaint is getting up at night. So just going through all the things that we talked about. Are you having any dietary influences? Would you benefit from pelvic floor physical therapy? Could you consider medications? Do you need to go to the bathroom more often for a little while? Going through all those steps, and then certainly come on in and see one of us, and we'll see what we can do to help you out.
Thanks, Sarah. You mentioned how important it is to do Kegel exercises, and you mentioned muscle groups. How do I know if I'm using those right muscles, and when should I do these exercises?
As far as when to know you're using the right muscles, when you get your initial physical exam, just like Sarah mentioned, she actually asks you to do Kegel and see, can she feel that you're using the right muscles? And this is when pelvic floor physical therapy really comes into play because they can tell you and they can teach you to make sure that you're doing things correctly and that you're getting the most benefit from doing these exercises.
Sarah, anything else to add?
No, that was pretty good.
All right, well, thank you. I'll back to back to Dr. Grytkowski on this one. I'm thinking about having surgery. What can I expect from recovery time if I have surgery or surgical intervention?
So as far as surgery itself, it is a same-day outpatient procedure when it comes to both the treatment for URGE, which would be like the sacral nerve stimulation, or the sling. So the sling is the most common procedure that we do here because stress incontinence is so common. So it's a same-day procedure, and the procedure itself only takes about 30 minutes. So it's pretty straightforward. Pain is usually pretty mild. It can be controlled easily with minimal medications. But the big thing is after the procedure, we want to see if you can actually empty your bladder. Because of some of the swelling that can occur after the procedure, there is a small portion of women who do have to go home with a urinary catheter. And we usually bring you back the next day or the next couple of days and make sure you can empty your bladder on your own. If you can't, you may end up having that catheter in there for a prolonged period, but that's very rare to happen. The big thing for recovery is not putting excess strain on that sling over the next 6 weeks, because over the next 6 weeks, your body is working on building in scar tissue and kind of solidifying that mesh. So it wants to grow around it and keep it in place, and that's what's going to provide support. So it's really important to avoid excessive heavy lifting, straining, even constipation to allow that mesh to set in place. And then also over the years to make it last as long as possible, because just like your native tissue, the mesh, if it's too much pressure is put on it, it can over time not work as well. So we do ask women to avoid, constipation, heavy lifting, straining, or power lifting, things like that. And we often have women wait until they're done having babies as well, because the concern it's going to shorten the lifespan of that mesh, as well as not straining when you go to the bathroom. So when you urinate, to actually just relax, let the urine come out instead of pushing down on the belly to get that stream started.
Thank you. Another question submitted. As we all mature and get older, we tend to live with problems assuming they are part of the natural aging process. How do you know when the problem is bad enough? When should I seek help or get others involved to help with a solution?
So I always tell everyone when they come to see me that what you decide to do and when you decide to do it is a very personal choice. I have some women that are willing to put up with a lot of leakage of urine before they want to do anything because they don't want to have surgery or they don't want to use medications. I have other people who come in and they say, I want to fix it. I want to fix it soon. And how can I do it? And so they might jump for a surgical procedure. That might be what's right for them. And so really the best thing is to figure out what are your options, what side effects and risks are there, and then what am I okay with having for risks and having for success of treatment as well.
Thanks, Sarah. Is there any last parting statements the two of you wish to make, or things we may have missed?
So I do want to mention that, we talk about stress as in itself and then urge incontinence, kind of separately here, but a lot of women have both. So a lot of it's a combination of what bothers you the most and what's going to give you the most relief. Because sometimes when we fix the stress incontinence, your urge symptoms get worse. And for some women, they would rather be leaking all day long than have urge all day long. So it's very individualized. And sometimes you're, pulling a little from both sides, but it's important that you verbalize what's most important to you so we can cater your care to you.
Thank you. Sarah, any other parting comments you may have?
Just, I want everybody to know that ultimately it's your choice, and we try to design treatment options and give you what is specific for your case. And really you need to decide what fits into your life the best.
Thank you. That'll conclude our question and answer session. I want to thank all of you for joining us today. And I specifically want to thank our guest speakers today who did a phenomenal job of urinary incontinence, stress incontinence, and urgent incontinence explanation and the answers.